to a step to ventricular dysfunction, dilatation, and at the end, heart failure. So this is a continuum. We need to tackle each part of it from happening. Like Dr. Nishin has elaborated, it's a process at the cardiometabolic level. It's starting with a lot of risk factors, giving you inflammation, black formation, and the atheroma, thrombosis, and for sure, all of those risk factors on the left, diabetes, hypertension, obesity, and the others can lead to these adverse events. The thing here, we can have some modifiable risk factors, but we should treat them, identify them, and giving the correct medication. As you can see, arterial stiffening also is one of the consequences of the chronic inflammation syndrome and long-standing hypertension, CKD, and for sure, metabolic syndrome. When you look here at the distensibility index from the brachial artery, you can see the further you have chronic inflammation, you will be having more stiffness, which gives you at the long term heart failure preserved EF, which is a visit is a part of its diagnosis and pathology. Now we have to weigh the benefit of the less angiotensin 2, giving you more vasodilatation, and also the depletion of nitric oxide, which gives you vasodilatation. So we have to balance these both. We have to get a high NO and a less angiotensin 2 before we reach to the heart failure stage. And we know that the targeted therapies for heart failure in most of the established guidelines and trials are using these specific pathways to tackle these, even if you are using ACE inhibitor for heart failure or are using like something like the Versigwat for the NO, the nitric oxide vasodilatation efficacy. Moving to the 2024 hypertension guidelines, and the same message here from the guidelines is starting with blood pressure reduction as per numbers, but do not forget that this should be done side by the cardiovascular risk reduction. How can we do this? We should prevent mediated organ damage for long-standing hypertension, which can damage your heart, kidneys, central peripheral arteries, even the eyes. And this should be screened for each patient before or during the treatment. You have to do the CKD approach with proteinuria or UACR along with creatinine. Heart, you should be assessed also with the ECG, AKG, and echocardiography cardiac biomarkers. And you may also go for the arteries with the cardiac Dopplers or the pulsed wave velocity or cardiac CT. Let's take this case and see how the cardiometabolic dysfunction is very common and really in our practice. This is a type 2 diabetic case with an A1C above 7, and she's having polyneuropathy, obese, CKD proteinuria, and you can see the echo showing ejection fraction preserved, but grade 1 diastolic dysfunction, and the patient is having peripheral arterial disease in the form of carotid stenosis and the high hsCRP and for sure dyslipidemia. If you continue to look at the CKM guidelines, you will find our patient in this stage, 2 to 3. How did we know this? You can see all the parameters. A1C is high, hsCRP is high, chronic inflammatory syndrome, apolipoprotein B is high, LDL cholesterol is high, and LP little a, which is a major risk factors now, a unique one, is high as well. So this patient, blood pressure through 3 successive visits is above 140. If we are talking about the old guidelines, you might consider this lack of sleep, long distance driving, or ever the patient is not just nervous from visiting the hospital. But the thing here is the guideline is giving you that in the ESC, this is a definite diagnosis of hypertension. You can see here, it depends on the out-of-office blood pressure monitoring, but you can take the office blood pressure monitoring for at least one additional subsequent office measurement. At this, you can diagnose in-office hypertension. As per the guidelines, you can see in the ESC, it is a grade 1 hypertension. In the ACC, the normal starts below 120, elevated 120 to below 130, stage 1, 130 to below 140, 140 and above, like in our case, is stage 2 hypertension in the ACC. So it is not only stage 1, it is stage 2 hypertension. As you can see, there is no further stage in the ACC guideline. So this is the final stage. Whatever is above this is still stage 2 until you reach to the emergency of hypertension. The same guideline from the kidney is giving you the same message. You can start with the patient on ACE inhibitors to get his blood pressure systolic below 120, which give you the best of the kidney outcomes. This gives you a preference of which medication you have to use to control hypertension. This is how you call hypertension treatment as efficacious and actually working well. You can see that the patient here should have a good sustainable control, no fluctuations, working in hypertension, non-dipper, and remodeling of HMOD and improving safety outcomes along with the renal benefit. The treatment guidelines gives you that the patient has to start with dual therapy as much as we can. The only exception here is those patients with a fragile blood pressure or very elderly, and the patient should start with ACE, ARBs plus calcium channel as combination. And here you can see that the difference between the ACE and ARBs is very well established, that those patients with ARBs are using only if the ACE inhibitor is not tolerated or not available. What you can see also from the ISH guidelines, the same idea, starting a single pill combination therapy with dual mechanism of action, going back to the dual full combination therapy. In the AEC guidelines, giving you the same low doses starting double therapy combination way, and you can now shift to a triple therapy as an early stage after the low dose double therapy. Why this is happening now, why this is update? Because we know multimodality mode of action means more efficacy and less side effect with lower doses from each of the three molecules. The same thing here from the ESH guidelines. The ACE inhibitor are preferred. In brackets, you use ARBs if not tolerating the ACE inhibitors. The same from the EC guidelines. The difference here lies between the ARBs and ACE, not on the angiotensin 2 pathway, but on the bradykinin pathway on the far right. You can see the bradykinin upregulation will give you a vasodilatation and for sure benefits on the apoptosis and in the blood pressure reduction. You can see here the levels of attention to using the prendiprel at a baseline and after the 1 year of treatment, it's far getting better lower than the use of the controls, as you can see here, for those patients with CAD. What you can see here also that those patients in the Brilliant trial having a bradykinin upregulation in the prendiprel arm, if you look at these patients from baseline to year one after, which leads both of them to less apoptosis, as you can see, after 1 year in the prendiprel versus placebo, you can see the apoptosis or cell-mediated death can actually regress. And that's why the cardiometabolic thing is real. And you can see here, even in the post-MI LV ejection fraction below 40, those patients were actually were trialed in these the SAVE and TRACE and SMILE and the HOPE trial, combining all of these. And Europa also gave us an evidence of benefit for MIs through cardiovascular death reduction. If you are using the ramiprel as an ACE inhibitor versus the placebo, the same efficacy you get from the prendiprel in the Europa trial from the cardiovascular death MI or cardiovascular or cardiac arrest reduction by 20% relative risk from the baseline if you are using the prendiprel versus placebo. And the ACE inhibitor and apoptosis is actually the best, can give you less apoptosis if you compare it with other ACE inhibitors from the same class. So now it is not a class effect. It should be individualized treatment according to your patient profile. And for those patients post-AMI, acute MI, they also had endothelial cell apoptosis less when you use a prendiprel in these patients. When you go to the advanced trial, when you try to combine the ACE inhibitor diuretic calcium channel to reduce the risk of the cardiovascular and the mortality outcome in type 2 diabetic patient, you will find the shift towards the benefit going to the prendiprel combination arms. And if you go more to the ACE inhibitor compared with ARB on the efficacy on the end organs and the HSCRP and tumor necrosis factor alpha, and we use one of these even in our clinics for the chronic inflammation, you will find the favor here is towards the ACE inhibitor, not ARBs, on all the inflammatory markers and apoptotic markers. From the new data here, the stronger cardioprotection from ACE and ARBs, you can see the REMI trial and the myocardial infarction reduction. When you use a meta-analysis of all of these, almost 300,000 patients, and on another arm, you can get the ACE is comparably actually higher in the cardiovascular reduction if you compare it with the ARBs. So only ACE inhibitor actually showed myocardial infarction regression in the ramiprel and in the prendiprel using the HOPE and Europa trials. If you compare with other ARBs like the valsartan, irbesartan, and the other ARBs we find in the market. So the different effects here from the ACE and ARBs lead it to have the first use in hypertension, and if not related, you move to the other regular ARPs. Even here, all the trials you can see from shifting to the left to the benefit of overall, you will find most of it coming to the favor of Brinjupre rather than other ACE inhibitors. This is the thought from my daily practice. If you're having a patient with hypertension, would you actually, having uncontrolled patient, would you increase the dose of the current medication, or will we use a different class of medication? I believe this was very well established answer from 42 trials, interpolation of the data over 11,000 patients on monotherapy versus combination. And what you can see here, that adding a new medication means a medication from a different class will approximately give you a 5 times greater reduction in blood pressure than increasing or doubling the current single daily or drug you are using. So adding a new class of medication gives you more efficacy and for sure less side effects. So does it matter how hypertension is controlled? I believe yes, because we know from different trials the cardiovascular mortality is not consistent with all the medication for hypertension. That's why you have to use those which give the patient the cardiovascular risk reduction. As you can see in the ASCO trial, the stroke was prevented by 23%, coronary heart disease events reduced by 13%, renal impairment even was reduced by 15%. And this you get when you use the correct ACE inhibitor along with other combination as recommended by the guidelines in the 16-year follow-up ASCOT. And this is beyond blood pressure control. So you achieve the targets mentioned in the guidelines as per blood pressure, but you also achieve a risk reduction in the cardiovascular and renal benefit. With reduction also you can see from the advance here at 28, less reduction in the mortality by the combining the calcium channel blocker and the ACE inhibitor, as we can see a combination in the market. So the heart failure guidelines also giving you, specifically in this preserved ejection fraction point of view, hypertension takes one in the score of heart failure. Why? Because the filling pressure actually is affected by the hypertension. And if you compare both guidelines, you will find that the parameters for hypertension mediated organ damage in LVH and LV dysfunction is the same you assign and endorse in those patients who are having heart failure preserved EF. So especially the same parameters, same LV chamber dimensions, same LV hypertrophic dimension, and the same proPNP levels as you can see. So this is a precursor of that. So if you do not treat hypertension early, you will get to heart failure preserved EF and hypertensive cardiomyopathy. Special population with hypertension like CKD proteinuria, ACE inhibitor is number one, and it is recommended by the kidney guidelines. And as we know, kidney guidelines recommend the ACE as a start, along with SGLT2 of the patients having proteinuria or diabetes mellitus. From the peripheral vascular disease, you have ACE and ARP as a class 2B indication. Moving to the patient's target here, it should be below 130, optimal 120 to prevent peripheral arterial disease complications. Moving to the chronic coronary syndrome, you're having the class 1 indication to use the ACE or ARB in brackets. So the preferred here is ACE. If you have a patient with hypertension and the chronic coronary syndrome, especially if you're having a metabolic syndrome, diabetes, and other risk factors. What about hypertension in CAD? We have evidence that RAS blockade is class 1 indication. Heart failure, we know LVH should be having RASI, and HFrEF, we know the RNA is class 1, and if not available, we use the ACE inhibitor. Hypertension with a lower extremity arterial disease. Also, RAS blockers can actually be used here. All of these are in line with the single pill combination and reminder of packing and reduce the polypharmacy for better compliance of the patient. And by this, I remind you back with the optimal hypertension definition, sustainability of blood pressure reduction, no fluctuations, non-depart coverage. You get it from the 24-hour coverage, reverse remodeling of mediated organ damage like LVH or CKD proteinuria, and the proven efficacy benefits as we have seen. My take-home message now, lifestyle modification for everyone, evaluate mediated organ damage, and Brendobrel is proven to reverse your mediated organ damage at the level of the heart, at the level of the kidney, and even peripheral arterial disease, de-stiffening distensibility as we've seen previously in the aortic distensibility indexes, and for sure those patients with heart failure preserved EF. The cardiovascular outcome should be actually in your pathway when you are treating the patient. You have to get the numbers along with the cardiovascular outcome side by side. Flexibility you get from the single pill combination actually is very important because the patient will respond better to add a new class of medication. And I believe the amlodipine, brandiplam, indapamide combination with different dosing will offer this flexibility. In young patients, do not forget to screen for secondary causes before you start the treatment. And thank you very much.
Thank you very much, Dr. Walid, for this excellent presentation. Dr. Walid unfortunately has to leave us because he has another important engagement. So this will allow us to ask him a couple of questions before he leaves. But we are hoping that you might come back at the end as well. Dr. Walid, I'm very happy that you gave that you presented the case that patient came to the clinic and blood pressure was 146 over 85, 148. This is very common scenario when we sit in the clinic, and the moment you ask the patient, oh, your blood pressure is high, you know the patient will say, oh yes, doctor, I had to walk from parking to hospital. I was or there was a big traffic. So they bring all kind of excuses not for us not to increase their medication or add another medication. How usually you persuade your patients when they come to clinic and their blood pressure is not controlled?
This is a very good question, and I believe the patient, even from the long time, they are seeing other physicians, and the blood pressure is 140, it's okay. So they even take the negative thinking, we do not have to change anything. So I give the patient that the reduction in blood pressure gives him survival straight away. So if we get this 140s, which is abnormal, to 120, by these 20 plus millimeter mercury, you get a chance of survival. And by this, I give him the previous and the previous readings. So the three readings here, it's high, high, high. Tell me, how can I stop helping you? I cannot. I shall start treatment straight away, and I will choose for you whatever is fitting for yourself. At the same time, I look at the comorbidities like the EGFR decline or even proteinuria. This allows me to push him to take the medications. I tell him this hypertension did this damage to your kidneys or your vessels. You have to take it because this is progressive. We have to stop it and reverse it. With this multimodality approach, the current situation, risk factors, the patient is mostly compliant and is telling even this will benefit the kidney, this will benefit the heart, this will benefit the blood pressure.
Yeah, thank you very much. I have two questions which is a little bit similar. If you have a patient who is already on triple therapy of ACE inhibitor, calcium channel blocker, and indapamide, and the blood pressure is still not controlled, would you add beta blocker?
I go back to this case, which is a very common case, to the heart rate. If the heart rate is above 80, so I know the patient is having sympathetic overdrive. So this also is a push to start beta blocker even at a higher stage. If the patient, especially those patients who are at younger age with a stressful lifestyle, beta blocker is a good medication, and it's now back to the four pillars of blood pressure medication A, B, C, D. Now beta blocker is one back to this, but the recommendation and the guidelines and my daily practice, it is not a stepwise approach. I just add it when I find the patient heart rate is higher than 80 in the setting state. We do ECG as cardiologists for everybody, so it's a very good thing to know the heart rate as baseline. But it's a good option to add as well, for sure.
Yeah, and there is another question regarding cough, ACE inhibitor and cough, the story of cough with ACE inhibitor. So one of our colleagues have asked that would the combination of ACE inhibitor and indapamide and calcium channel blocker actually decrease the cough, and what is the evidence for that?
100% it decreases it. I will tell you something. Even two combination only. Sobrendebrel is it's a myth that it causes cough for everybody. But for sure, because of the bradykinin pathway, it can cause this. But if you combine it with the amlodipine, you have the venodilatation from one side, and it counteracts this. So it goes down by almost 1% only of your patient, or 0.1% only in your patients will get cough if you combine the prendoprel with the calcium channel blocker. If you add the endopamide on top, this is very far away. You will get a cough actually. So adding a double will get you less cough, reaching almost below 1%, and adding more, a third molecule will give you less cough than even the double. So combination here gives you efficacy and for sure side effect from both, as per even the ankle edema from the amlodipine will actually regress if you are adding indapamide and the ACE inhibitor. So it works on both directions.
Yeah, and one question just now came up is, do you know of the percentage of patients who develop cough with prindopril? It's very difficult to say what percentage, because patients may have cough for different reasons. I mean, I ran heart failure clinic, so lots of patients have cough because of heart failure, and also these days, even post-viral infection, they develop chronic cough. But per se, by ACE inhibitor or perindopril induced cough, do you see a lot of patients or no?
In the daily practice, I don't see much, but remember, we start most of the patient with hypertension on dual therapy from the start. So I don't start mono at all. So the percentage of cough I get from the combination is minimally ignorant. I couldn't stop the medication for cough. Nobody came with me and pushed me to stop the medication for cough. So we start with dual, we get less side effects. Starting with a triple low dose as per the guideline, second step can even get you less and less side effect.
Excellent. Okay, Dr. Walid, I think it's time to move on. But before we say goodbye to you, I would like you to leave us with one short take-home message for me and for audience.
So my message here in hypertension, try not to have inertia to increase the medication and start with dual. This will solve most of your problems. Second thing, estimate the risk factors along with the hypertension because it can let you choose certain medication over another. The third one here, use combination or triple as much as you can. You will get blood pressure and target, less side effects.
Thank you very much, Dr. Walid, and I hope you enjoy the rest of your evening. And now it's my great pleasure to invite Dr. Mariam Al Said, my dear colleague and friend, who is going to talk to us about growing burden of dyslipidemia. Dr. Mariam, please.
Thank you, Dr. Nushin, for the kind introduction. I will just be sharing my slides. Okay, so I'm just confirming that you have the slides on display.
Yes, we have.
Yes, okay, perfect. So just to maybe reintroduce a little bit on my background, mainly because I'm interestingly an endocrinologist, so I deal with patients with diabetes. But what I'm going to talk to you about today is dyslipidemia. Okay, so there's another talk coming up about diabetes. So currently I'm at Mediclinic City Hospital. I was until recently also at Mediclinic Dubai Mall. These are my disclosures. And I like, Dr. Nushin, the fact that when we started this discussion, and Dr. Walid has really continued the theme of CKM or cardiometabolic disease. And I think this is also reflected in the specialties that are delivering the talks today, a mix of cardiology, internal medicine, endocrinology. It's really hard to dissect these conditions from each other. And I've heard, comments from some people describing it as a package. You get one condition and you get the others. And as you had clearly explained early on, it's mainly because they have similar genetic risk factors for metabolic disease and a similar root cause or pathological outcome or process of insulin resistance leading to inflammation, to endothelial cell dysfunction, to atheroma formation, and you have not only the cardiovascular system affected, but also glucose regulation and fatty liver, as well as an elevation in blood pressure. And a lot of the common reasons, apart from genetics, which we can't change at this moment in time, is weight gain, obesity, lifestyle factors. So you have multiple factors coming in together really to lead to this. Now, dyslipidemia is a very broad term. And there are many kinds of dyslipidemia you could find because, again, if you run a lipid panel on any patient that comes to you, there's many components. So we have the triglycerides, we have the LDL, we have HDL, non-HDL. Now we have even measurements of ApoB, of lipoprotein little a, of ApoA. And the patients I find with time, the more patients you see in clinic, it takes a good bit of time to explain the lipid profile to the patients. I do think it's worthwhile explaining in an understandable way because at the end of the day, patients need to know why we are prescribing them certain medications, why we need to order certain tests, why we need to follow them at a certain time frame. And if they're not on board with you and they don't understand the potential impact of what they have, they're not going to be compliant. So if we look at the map here with estimated prevalence based on multiple studies really across the GCC region and including widened West Asia region, there's varied prevalences, but if we look at the UAE, it's up to 75% prevalence of dyslipidemia. Now, this could be mild dyslipidemia, this could be severe dyslipidemia, but what can add to this, so it's highly prevalent, it is a risk factor for cardiovascular disease, but what adds to this is that not everybody is controlled. So we have low control rates, so they're not achieving LDL-C targets. We'll talk a little bit more about that soon. There's no adherence to therapy. If therapy is even initiated, there could be clinical inertia, there could be access issues, so it could be patient-related, healthcare physician-related, could be health system-related that leads to this. In this era, we're also dealing with misinformation, especially with the topic of dyslipidemia. And I'm sure many of the colleagues who are tuned in today are struggling with that. So if we speak about dyslipidemia specifically, it is a cardiovascular risk factor, yes. But again, similar to what Dr. Walid highlighted with hypertension, it's quite rare that you'd find one cardiovascular risk factor alone. It's a spectrum, so it's a chronic disease, so it's a progressive disease. So yes, it may start mild and slowly worsen with time, depending on lifestyle factors, on other factors. But frequently, if we look at this study, the ACE study, we find that was done it's a sub-analysis of the ACE study done in the UAE, and it's looking at the cardiovascular risk factor burden. Now, we know we have a very high rate of metabolic disease in the UAE. I mean, looking at our patients who have diabetes alone, among the adult population, it exceeds 20%. And among the Emirati population, at least, there's at least another 12% or so who have pre-diabetes. And these are just people who were tested. Obviously, there are those who haven't even been tested. Now, we have 60%, if you want to look at three factors even, three risk factors, okay? So not even 4 or 5 of 6. We have 60% of those with cardiovascular risk factors having at least 3 risk factors together. And that's really relevant because if you're discussing the lipid profile with your patient, they just run a routine test or they know that they have a problem, they are diabetic or they're on cholesterol-lowering medication. They may minimize the risk if you use certain terminology, such as with prediabetes, we see this often, you say, well, the glucose is a little high. It's not bad, it's just a little high. That's prediabetes. Or you say that the LDL is a little high. So when you keep using terminology like this without properly categorizing the risk and without looking at the overall picture, what if you have a person who has 6 of these little increases? So they're a little bit high blood pressure, a little bit high cholesterol, a little bit high sugar, a little bit extra weight, a little bit deranged liver enzymes. You're looking at 5 or 6 risk factors in one person. So yes, you're probably not going to deal with this person in the same way as somebody who has less number of risk factors. And if we look at the ESC focused 2025 guidelines, so we had the 2019 European Society of Cardiology guidelines for the management of dyslipidemia, and there was a focused update in 2025. And we can see that in the focused update. So with hypertension or diabetes, yes, we do have categories as well. You have stage 1, you have stage 2, you have pre-diabetes. With dyslipidemia, it's not so much. Yes, there are severity levels, but it's different depending on your patient and the patient's risk factors. So it makes it a little bit more complex. Usually, doctors are in a very busy clinic and you have to deal with multiple things. And the last thing you'd want to do is to try to put your patient in a box specifically for cholesterol. You may have to pull up a calculator. I'm really fond of the new AHA ACC Prevent CVD calculator. I think it's really convenient. But yeah, you could use the SCORE2 calculation from the ESC. And what you can see is that you have different targets depending on what risk factor your patient has. I'm not going to target the same LDL-C in somebody who already had stenting and had a myocardial infarction in the past, established atherosclerotic cardiovascular disease versus someone who hasn't had it, right? Again, someone who has diabetes is different to someone who doesn't have, someone who's smoking. So I think it's worthwhile. Again, you're running busy clinics, but using the calculators, you can choose either the SCORE2, you want to use the Prevent CVD to really put your patient at least one time into a box, document it in your notes so that you know how you can deal with them appropriately and that you're not minimizing, their risk factors. And we spoke a lot about LDL, and I guess the discussion with LDL is that a lot of the blame for cardiovascular disease is put on LDL, but we understand that there are other atherogenic particles. So probably we have non-HDL as well, calculation, and we have ApoB. And some physicians would say, well, I don't test for this. Well, it depends whether my lab has the profile or not, or I check it at baseline. It probably makes sense to check it at baseline in certain individuals. Which types of patients would I think of running maybe an ApoB test on them? Probably at baseline in somebody with metabolic disease, so somebody with type 2 diabetes, maybe somebody with hypertriglyceridemia and elevated LDL, both, right? So it tells you it's probably a better marker at their overall cardiovascular risk. And you could have 2 individuals with elevated LDL, but one of them has elevated ApoB and is probably at higher risk. And it's a similar way when we check lipoprotein little a, at least once in a lifetime. We're looking for additional risk because it's going to help us make a decision of how aggressive we're going to be with our cholesterol lowering treatment, and also how, whether we'll start treatment if the patient wasn't on treatment. And it will probably give you an idea whether you want to refer this patient to cardiology for further assessments such as imaging, maybe a stress test, as what is deemed appropriate. So it's something worthwhile thinking of when you're trying to classify your patient in a risk category. And if we want to look here, as I mentioned, ApoB versus non-HDL or LDL, we can see it's relevant in patients also who are on statins. If we look at this study that looked at all-cause mortality and myocardial infarction, it's more likely that you will have elevated mortality and elevated risk of myocardial infarction when you have elevated ApoB concentration Not that LDL-C doesn't do it, but it gives us a better marker overall, and so does non-HDL-C. You may be wondering, well, is this a target I should look for? LDL in the 2025 update, ESC dyslipidemia update, and also in the 2026 AHA ACC, they still focus on LDL-C. And it is a good target, but yes, with certain individuals, if you had done a baseline assessment, it's probably worthwhile also looking at their non-HDL-C, especially somebody with hypertriglyceridemia, and maybe you need to address that. Maybe you need to add something like icosapent ethyl. Maybe you need to consider PCSK9 in certain individuals. So really, it depends on your patient. There's no one size fits all. And this is reflected as well in the ESC 2025 guidelines. And you can see a variety of regimens for the treatment of dyslipidemia. And the percentage is reflected here. So you have everything from moderate intensity statin on its own, or whether you're going to give a high intensity statin, whether you're going to give ezetimibe, bempedoic acid, which we don't have yet, but hopefully we'll have it soon. Different kinds of combinations of medications, PCSK9, all kinds of, multiple agents. And it gives you roughly percentage of reduction in LDL-C. So really it depends on how high your patient's LDL-C is, what risk category they're in, and how much you want to lower. If you have someone with LDL-C of 200, LDL-C of 200, right? So not total cholesterol. Probably giving them a moderate intensity statin on its own is not going to make them reach a target that you're happy with, especially if the target was supposed to be below 70. So you're not going to reach that target. So you know that. So why waste their time? So there's clinical inertia. So don't go for something low and see them in 3 months later and then gradually increase. It may take you a year or more, maybe even more than a year to reach a target that's reasonable. So keep this in mind when you select the treatment for your patient. And dyslipidemia management in general, if we want to look at all the drugs we have available, so all the ones we mentioned there, PCSK9, statins, all the different, ezetimibe, not only your selection in giving the drug, but it's the patient's ease of taking it and the adherence to the therapy. So obviously, the more medications you give a patient, the less likely that they'll be compliant because they have a load of tablets to take. So it makes sense if maybe you want to think of simplifying it. Maybe you want to give them something less frequent. Maybe you want to give them a combination drug. And again, we see that those who are given a single pill combination drug, we see this with multiple conditions. We see this with hypertension. We also see it with diabetes. When you have combination drugs, the adherence is better, the outcome is better, okay? And unfortunately, more than 50% of patients who are given statins discontinue the statins at some point. And there's so many reasons for it. Yes, misinformation is a big thing these days, but I mean, simplifying the regimen, and obviously you don't want side effects. So from the racing trial, in this trial, they looked at more than 3,000. So almost you're looking at 4,000 individuals with atherosclerotic cardiovascular disease. So these are high-risk patients. And they compared giving them combination of a moderate intensity statin combined with ezetimibe versus a high intensity statin on its own. So if you think of something like rosuvastatin, for example, so if you give someone, say, 40 milligrams of rosuvastatin, a high dose, or whether you give them 10 or 20 milligram of rosuvastatin with ezetimibe added to it, it was non-inferior in terms of MACE. So it wasn't taking the combination lower dose statin with ezetimibe didn't have additional MACE, okay? So it was non-inferior, but interestingly, there were more patients who took the combo drug with a moderate intensity statin who achieved LDL-C target, 72% versus 58% in the other group on the high intensity statin. And they had better tolerance overall. So that was very, very interesting to see. And if we want to look at this meta-analysis as well, so again, same thing, but with different statins. If we want to look at simvastatin, atorvastatin, rosuvastatin, again, if you add the ezetimibe to a regular dose rather than doubling the dose of the statin. So imagine that doubling the dose of the statin only gave a 6% further reduction in LDL-C, but combining it with ezetimibe was much more effective. And if you think about it, probably less intolerance if really, you know, it's rare, but yeah, if they were statin intolerant, it's much better for them to get a moderate dose in this situation. Similar finding in the Mrs. Rose trial. So they looked at patients here with primary hypercholesterolemia. And again, compare rosuvastatin on its own, different doses with the combination of rosuvastatin with ezetimibe. And again, you're having more efficacy in LDL-C reduction. And by the way, in case you were wondering, because we were discussing non-HDL cholesterol, and we were also discussing ApoB as risk factors, and we actually said they're a little bit more accurate in predicting. There's a better correlation of having elevated ApoB with having major cardiovascular, adverse events. And can this treatment, say statins on their own, or even a combination of statin and ezetimibe, lower the non-HDL cholesterol and ApoB? Yes, it can. And yes, when you take, so it's not only targeting LDL, it's also targeting the other atherogenic particles. And again, if you think of us treating our patients, and again, I'm pretty sure we have all kinds of specialties following the talk today, from endocrinologists to family medicine, internal medicine, cardiologists, nephrologists, and we deal with chronic disease. And when you're dealing with chronic disease, you want to make sure that you treat early, because it's a cumulative exposure. I don't want to be exposed to a condition that's damaging my organs, leading to end organ damage for a very long time. I want to make sure I treat it early. And we know that the outcomes are better for any chronic disease. The earlier you start, the less end organ damage you have. And obviously, if you start the treatment early, so you really need to think. And if you look at the 2026 ACC and AHA guidelines, they also have reduced the age of considering treatment to 30 years of age. And we know with familial cases, we even start with children. Again, the combination treatment, if you look at the bar chart there in green, and you want to compare the treatment using combination therapy with those who are achieving target LDL-C, look at the difference there in those taking combination therapy at 1 year follow-up. Should we worry with all these medications, effective medications, should we worry that the LDL is too low? I mean, I guess there's a scare out there, some people saying, well, you need your cholesterol because it's responsible for the sex hormones, and you need it for your brain, and otherwise you'll get dementia and all kinds of things. Well, you don't want vascular disease, because vascular disease is the #1 cause of dementia. And no, there is no evidence out there that there is a level of LDL that's too low, okay? And if you look at the 2025 update of the ASC guidelines, for very high-risk individuals, they even advocate for below 40 milligrams per deciliter. So start early for more effective changes. And again, the ESC guidelines, so what do they say? The ESC guidelines say intensification of lipid-lowering therapy, even in acute coronary syndrome hospitalization, is recommended. So again, not only in chronic disease, but it's also important to consider even with ezetimibe in acute cases. And this is just a comparison of the 2025 ESC update with the AHA 2026. Very similar to each other, very minor differences, maybe additional risk category with the ESC, but you could see that there's absolute values given in the European guidelines. So they tell you say with very high risk patients, LDL should be below 55. But with AHA, they're more with percentage reduction from baseline, and then maybe they give a cutoff of some value. So it's really, if you use those calculators, they really help you in clinic because they give you the the outcome, the recommendation that you should follow. So now that we know that elevated LDL, elevated non-HDL, elevated ApoB, dyslipidemia in general, part of cardiometabolic disease is a risk factor for adverse cardiovascular events, for MACE, is a risk factor for other conditions. Are we really doing what we're supposed to do? Not really. So unfortunately, despite the overwhelming evidence of the benefits, proportion of patients with optimal LDL, and again, this is replicated in any study you look at in most places, but unfortunately here in the GCC as well, they're not achieving targets, right? So look at the green line. So this is if we're looking at different types of patients. So if we want to look at one bar chart is for those are very high risk, and what type of treatment they're taking. So the green, we want more green on these bars, right? We don't want the blue, we don't want the gray. And those achieving the most green, so the most on target, are the ones on combination therapy. So we really know that combination therapy helps. It's less of a pill burden for our patients. So my take-home message really is that despite individual variations, the capacity of LDL reduction by statin monotherapy and combination is predictable. We kind of have an estimate of how much lowering we can get. You need to treat a target. You need to know what the target is for your patient, right? Every patient has a different target. Combination of a statin and ezetimibe is more powerful than a statin alone, such as even a powerful statin such as rosuvastatin. And the combination leads to a further significant reduction compared to monotherapy, with a significant reduction in the risk of cardiovascular events. And it's the risk really that we're treating. So thank you.
Well, thank you very much, Dr. Mariam. I was reading the questions. That's why I couldn't put the screen and the voice on. Anyway, let us go to the last presentation, and we would like to have you, Dr. Mariam, at the end to answer the questions that I can see one by one appearing on the screen. So our last guest speaker is Dr. Tariq Bakri, who's going to talk to us about diabetes and metabolic factors. Dr. Tariq, please.
Thank you very much, Dr. Notion. I'm going to share my slides. Can you see the slides?
Yes, we can see it.
Okay. Thank you very much for everybody who's attending, and thank you for Servier and the committee to ask me to be part of this scientific meeting. My last, I'm going to be the last to talk, so it's always difficult to be the last, but I will try to be as brief, as practical as possible. So Dr. Mariam and Dr. Walid addressed two very important cardiovascular risk, and I'm going to try to address the third one, which is type 2 diabetes. This is a disclosure. All the information is presented is my opinion. So basically, I think the first few slides will be a little bit repetitive, but it's nice always to emphasize that we're practicing in a region with very high-risk patients. So you can see that diabetes is basically high prevalence globally, but in the Middle East and North Africa region, we have really the highest prevalence, and it keeps going up every few years. And unfortunately, unless we do something about it and help our patient to get treated early and get control, we will really continue to have the significant morbidity and mortality from diabetes and the other cardiovascular risk. And part of it, genetic predisposition, but in our region, we have a lot of high risk, high prevalence of overweight, obesity, sedentary lifestyle, urbanization, and poor nutritional habit. So that's the reason we have high prevalence of diabetes and also pre-diabetes. So as already mentioned, we have multiple cardiovascular risk contributing to morbidity and mortality, in particular macrovascular complication. And you can see here in this study, they looked at most of the cardiovascular risk, and you can see the first 7, and which is very important. But 3 of them are the most important one, is the A1C, the blood pressure, and the LDL. But you can see here for all patients with or without coexisting condition, A1C carry much more predictive value, especially when it's not controlled for cardiovascular disease. Of course, the more we can control A1C with the other risk factor, the better we can help our patient to prevent mortality and morbidity. And hopefully, if we can control most of the cardiovascular, they will be at much lower risk to develop MI, stroke, and other macrovasculars. So you can see here on this side, if we compare patient with type 2 diabetes and not with or without type 2 diabetes, they are susceptible, and they will get most of the cardiovascular disease from MI, unstable angina, ACS, heart failure, but also they will have TIA and stroke, and also peripheral vascular disease. So definitely type 2 diabetes is significant risk factor. And unfortunately, any time the patient is diabetic and even pre-diabetic, it will amplify any other cardiovascular risk. So you can see on the right side as an example, if we look at the LDL level, definitely when we have diabetes on the top of the high LDL, the risk of cardiovascular disease get amplified. Same for hypertension, same for any other cardiovascular risk. Again, going back to our area, we really need to pay more attention about early glycemic control, because you can see here in our area, most of the time, only 17% of our population, diabetic population, they have A1C less than 7%. 80% more than 7%, and 50% more than 8%. And of course, the higher the A1C is, the worse predictive for cardiovascular disease and microvascular disease. And unfortunately, most of our patients, you can see here in the Discover study looking at our region, the majority of the patients are not really well controlled. Some of them, they are not really having monitoring and like routine A1C, and the majority, they are above 8% on one monotherapy, which most likely, most of them metformin. So starting second line therapy or third line therapy, usually it's really, we are very behind. We wait too long to start second line therapy, and that's putting our patient at higher risk of complication. With the recent study from the PAC-MIA, which was published in 2023, again, it really showed us that in our region, most of our, actually the majority, 99% or 100% of our patients with type 2 diabetes, they are at high or very high risk for cardiovascular disease. And as mentioned before, they have a lot of other risk factor, hypertension, diabetes, obesity, smoking, and so on. And you can see really, unfortunately, looking at multiple cardiovascular risk, and the goal according to the European Society of Cardiology 21. From A1C point, you can see only 37% getting to the goal, less than 7%. And also, if you look for the hypertension, for the LDL, for the obesity, all we're not doing really great job for our patient. Of course, there are multiple reasons for that. We'll try to address our part as a doctor, and we try to eliminate our inertia and help our patient with education for better adherence and so on. And as you will see later on when we talk about the management of type 2 diabetes, which is now two parts. One part is the hyperglycemia control, and the other part, cardiovascular and renal protection independent on the A1C. And those two medications really help us with this, the SGLT and GLP-1. You can see very low percentage usage at that time. It's improving overall, but still, I think we are way low below what expected for such high and very high risk patient in our region. Again, you know, the UKBDS, you know, the importance of A1C reduction. We know that 1% reduction in A1C will give us a significant reduction in micro and macrovascular disease. So I don't want to bore you with all of those information, but it's always nice to remember it, and also nice to share it with the patient to motivate them to do better for better control and early control. And even with the UKBDS, we can still see over 44 years of follow-up, the intensive therapy with sulfonylurea or insulin versus conventional therapy with metformin and lifestyle, we can see still the benefit persists. So this is what we talk about, the legacy effect. So that's the reason very important to get the blood sugar under control very early, because even down the road, if the control get less than what we want, still we have the benefit and the legacy effect. So you can see here, after 24 years post-trial, we still get 10% reduction in any diabetes-related endpoint, 17% reduction in MI, 26% reduction in microvascular disease, and 10% reduction in all-cause mortality. So those all should help us as a physician and the patient to really recognize the importance of early detection and intensive management in type 2 diabetes. And so we all know that if we don't do the control for our diabetic patient and not to get our A1C to control and not utilizing the good medication for cardio and renal protection, the patient will die more, will have more complication, less quality of life, and including micro and macrovascular disease. So you can see here about the 12 randomized control studies. They looked at macrovascular outcomes, microvascular outcomes, and also for safety. And they looked if intensive glycemic control versus standard therapy. So we can start with the microvascular complete outcomes. You can see that the hazard ratio is really much better with much better with intensive therapy, 0.88, retinopathy 0.85, nephropathy 0.71. If we look at the macrovascular outcomes in those meta-analysis, the non-fatal MI was really also significantly less with hazard ratio 0.84, but the rest of the macrovascular outcome was almost the same. That really tells us that definitely we really need to control the A1C, but it's not enough by itself. We have to utilize the cardiovascular and renal protection medication, and also to control all of the other risk factors already mentioned so far. Here again, showing the importance of holistic approach to control sugar and other cardiovascular risk. So you can see here with intensified treatment versus 3-year delay or 6-year delay or versus the standard care, definitely we see much better and much less incidence of cardiovascular events. Again, I have to remind you with the STENO-2 trial, which is, we know it's a randomized controlled study. Sometimes it's not very easy to duplicate in our practice, but that should be our optimal goal. So again, here showing that if we control all the, or the majority of the risk factor like A1C, hypertension, dyslipidemia, using ACE inhibitor or ARBs for microalbuminuria, antiplatelet when it's appropriate, we get 53% reduction in both the cardiovascular endpoint and the microvascular. And again, looking at follow-up after 21-year-old, after 21-year follow-up, still you see significant results. So that again should motivate us as doctors, as patients, to control all the risk factor, including A1C. So we have mortality less, 45% less, patients survive more, about 8 years more. The time to first cardiovascular disease, again, delay about 8 years. And of course, microvascular complication, much better. So better quality of life. So going now to the management of diabetes, as we said, we have two parts. We have the hyperglycemia control, which is very important, and we have the cardio and renal protection. So it really now works hand to hand, independent on the A1C. We know the defect for type 2, so I'm not going to bore you with it, but we have multiple medication addressing different defects. So we have metformin work on the increased hepatic glucose production. We have metformin and TZD working on the glucose uptake and lipolysis. We have the incretin therapy, DPP-4 inhibitor, GLP-1 receptor agonist, and also we have the sulfonylurea. So we have really multiple medication work on different mechanism. We have also the SGLT2. We know most of our patients will need more than one therapy most of the time. And now it's a progressive disease. So sooner or later, we might need to do 2 or 3 medication, and we might go to insulin or insulin from the beginning if the patient has weight loss and catabolic syndrome symptoms. So our goal when we want to use anti-diabetic drugs, actually, it's the same purpose. We need to control the glucose, but we can do it in a different pathway, but utilizing different mechanism of action always work better, as we mentioned in hyperlipidemia management, in hypertension, same for asthma. When we tackle different pathways, we always get better and earlier benefit. So, our management should be really tailored to our patient profile and characteristic and comorbidities to utilize the best medication. And of course, some patients might need to be on monotherapy, but the majority from the beginning, we might need to go for combination agents. So I will just remind you with cardiovascular outcome trials. So for DPP, we know, unfortunately, it doesn't really help too much in cardiovascular prevention. Definitely, it will help with the hyperglycemia control, but to a lesser degree of other medication like GLP-1, SGLT2, and sulfonylurea and bioglitazones. And we know that we have to be careful when we use DPP-4 in heart failure, in particular saxagliptin, where it showed some hazards. Then, in 2015, 16, we had the study from the GLP-1 receptor agonist, the leader with liraglutide, the sustained with semaglutide injection, and later on we know also Oral semaglutide has also reduction in MACE and cardiovascular protection. We have a rewind study with dulaglutide, and later on with tirzepatide. Now also we have the study which showed cardiovascular protection. So we know GLP-1 receptor agonist on the top of the hyperglycemia control as a reduction of A1C. We have the cardiovascular protection. With semaglutide injection, we also have renal protection as one of the pillars for CKD in diabetic patient. So it is one of the medication we try our best to utilize if there is no issue with cost and tolerability or contraindications. Then we have also the SGLT2 inhibitor. Again, multiple studies showed the benefit for cardiovascular protection, for renal protection, weight reduction, no hypoglycemia. Again, showing that SGLT2 with GLP-1 most of the time is something we need to utilize for our patient for two reasons: the hyperglycemia control and the cardiovascular and renal protection. And we know that most of our patients also come with CKD. We have to screen them for, and we have to try to slow the progression for CKD. So we know that SGLT2 and the non-steroidal MRA phenylalanine also showed significant reduction, cardiovascular and renal. So it's also part of the pillar. So we have different guidelines, but I think all the guidelines really tell us exactly the same. So if we go with the ACE 23, we have two algorithms. We have algorithm with comorbidity and algorithm without comorbidity. So always we have, whenever we decide about the treatment for type 2 diabetes, we have to look for any comorbidity. So if the patient at high risk for cardiovascular disease or established cardiovascular disease, then GLP-1 receptor agonist or SGLT2 should be on those patients if there is no other reason not to, either alone or on the top of metformin if we need also efficacy for the hyperglycemia. If the patient has heart failure, SGLT2 inhibitor. If the patient has TIA or stroke, GLP-1 receptor agonist or TZD, pioglitazone by name. And also if there is CKD, SGLT2 inhibitor or GLP-1 or both. So definitely we will start with those medication, see if we can reach the goal for A1C. If not, we try to use the other one, whatever we start with. We can add metformin also for efficacy, and then we start adding other medication. Sometimes sulfonylurea is also an option to add to get the hyperglycemia and A1C under control, usually in combination with other cardiovascular protective and renal protective medication. And you can see here also we have to really, as Dr. Mariam said, in hyperlipidemia, we need to know where we are at baseline. So if our baseline is really high and A1C is high, above 7.5 or 8, then definitely starting with combination therapy, it's much better and we can reach our goal much faster because early control will give us much better reduction in cardiovascular and microvascular complication. And we go through the algorithm. If the patient does not have comorbidities, then again, we have to look at the characteristic of the patient, overweight or obesity, then, GLP-1 receptor agonist or tirzepatide or SGLT2 might be a good start. If the patient has hypoglycemia risk, again, those medication does not really offer good efficacy without hypoglycemia. In such cases, we might really need to avoid sulfonylurea. If the cost an issue, then we have to work with the patient. And sometimes although we know we have optimal treatment with GLP-1 receptor agonist or SGLT2, if the patient cannot afford, we can ask them to bring it from their country sometimes, which is cheaper. Otherwise, we have to offer them other treatment like TZD, sulfonylurea, DPP-4. So we have to really do whatever we can to control the sugar to start with, then we can see whatever cardiovascular protection medication to add. Again, depending on the start of the A1C, we can start with 1 or 2 medication and then add a few other down the road to get the control we want. Same in the ADA guidelines, we have like with comorbidity, without. So I'm not going to repeat for the sake of the time. It's exactly the same comorbidity, the same recommendation. Also, without comorbidity, we have to look at weight, we have to look at risk of hypoglycemia, cost, and other issue and decide what's the best treatment. Also, not to forget that our patient, most of the diabetic patients, they are at very high risk or they have MASH or MASLD. So again, here, if those patients, they have this GLP-1 receptor or terzepatide or bioglitazole or combination, might be also one of the options to decide. So as you see, we have a lot of tools. We have a lot of medication we can use, but our goal to get the control, number one, and to utilize whatever the best medication with our comorbidity and cardiovascular risk and so on. So, again, to really emphasize on the importance of addressing all the cardiovascular, which we saw in the STENO-2 trial and the benefit. So now the recommendation now is to control A1C, to control blood pressure, to get the LDL to goal. But even regardless of the A1C, we have to really consider the cardiovascular and kidney protection, which we can get from the SGLT2, the phenylalanine, and the GLP-1 receptor agonist. And for the renal protection with the GLP-1, it's only weekly injectable semaglutide. We have to, if the patient has albuminuria or CKD, we have to try to get 30% reduction at least in the albuminuria to reduce the risk of cardiovascular and slow the risk of CKD progression. We have to screen a diabetic patient for heart failure, so we can definitely, with history and physical exams, and we can do BMP, and if it's abnormal, we have to proceed with echo, because our diabetic patient also, they can come with heart failure, and then we have to maximize their pillars, either HFpEF or HFrEF. If the patient, they have CKD, again, we have to try to maximize the 4 pillars for the CKD, diabetic CKD, on the top of good A1C control and other cardiovascular risk. And I will finish with sulfonylurea, which is something we don't use as before, but it is still one of the medication we might need to consider on the top of other medication or combination to get the A1C control. And definitely, we have now like the second generation sulfonylurea in the form of a glycoside MR, or which really give us significant reduction in the like combined major macrovascular and microvascular event, about 10%, in particular reduction in nephropathy. Efficacy, definitely we know sulfonylurea really is a good medication to bring the sugar down, the A1C down. We can see from the advanced trial when we intensify glycemic control utilizing glycoside MR versus standard glycemic control, we can really reach the hemoglobin A1C less than 6.5 in faster and more patients. Again, we see the same that sulfonylurea, in particular glycoside MR, definitely in regarding efficacy and reduction in A1C, it's more stronger the sitagliptin, that DPP-4. And what differentiates glycoside MR from the other sulfonylurea, all of them, they really work well on the A1C, but with the glycoside MR, we see less hypoglycemia, although we have to be careful with it and keep it in mind, but it's less than the other sulfonylurea or older generation of sulfonylurea. Also, in one study, it showed that using glycoside versus glimepiride, we delay the utilization of insulin by 6.5 years. Regarding weight gain, which is something we always consider when we're utilizing sulfonylurea, is much less than the other older sulfonylurea. And if you see here on the slide, looking at 10 years of evidence-based regarding renal protection, in any way you look at it, as a new onset of microalbuminuria, reduction in 9%, new or worsening nephropathy 21%, new onset of macroalbuminuria 30% reduction, and overall much reduction towards end-stage renal disease. So if we need to utilize sulfonylurea, glycoside MR showed really good efficacy and more tolerable than the other ones. And before I finish, we always have to remember that many of our patients, they are pre-diabetic for a while before they go into diabetes. So we have to screen the high-risk patient. And if they have pre-diabetes, definitely we have to counsel them, do aggressive lifestyle modification, and then depending if the patient overweight or obesity or not, if they are overweight or obesity and they can tolerate and afford utilizing GLP-1 receptor agonists, then that would be the best way to do it. If it fails, then we will add metformin or TZD. If they are not overweight or obesity, then we can, on the top of aggressive lifestyle modification, we can usually we use metformin because less side effects and more affordable. So to summarize my presentation, basically, and look at it as a practical for every patient I deal with for diabetes. So my goal is really to do two things: control sugar, and definitely it's like A1C should be individualized depending on the patient profile. We have to get the A1C to control, not in 6 months or 12 months, as soon as possible, hopefully within 3 months. We have to consider cardiovascular disease protection, CKD protection, heart failure. So, and whenever we choose medication, we can look at the efficacy, weight reduction, risk of hypoglycemia, cost is an important issue in some patients. Look at combination, utilizing synergetic therapy with different mechanism of action. Of course, look at contraindication, simplify the regimen as possible. Definitely, we have to look at the comorbidity of the patient and get the preference of the patient, because they are the one who, at the end, who will take the medication. By doing all of this, hopefully we can get the patient asymptomatic. If they have symptoms, we can decrease mortality, we can decrease complication, macrovascular or microvascular, better quality of life. Of course, we have to remember that some of our diabetic patients, especially before we really label them as non-compliance or not adherence, we have to educate them, motivate them. We have to screen them for any depression, because that could be the reason for the non-adherence. And of course, we should also refer them whenever needed to ophthalmologists and other supportive subspecialty. And immunization is very, very important for diabetic patients since they are high risk. So to summarize, basically, unfortunately, type 2 diabetes is a progressive disease, but we have really multiple tools to utilize. Early control is crucially important in the diabetic management. Glycemic control was and is still an important aspect. But now, on the top of cardiorenal protection, it's hand by hand. If we need to utilize sulfonylurea, glycoside MR, because it's effective, has more tolerability and safety regarding weight and hypoglycemia, is one of our preferred sulfonylurea, and we should really utilize it whenever we need it on the top of other medication to get our A1C under control. Thank you.
Thank you very much, Dr. Tariq. After these two beautiful presentations by Dr. Tariq and Dr. Mariam, I can see that there are a lot of questions and we don't have enough time. But let me start with Dr. Mariam. One of our colleagues asked what would be the best the lipid lowering agent for a patient who is on hemodialysis.
So what is so if a patient, obviously these patients are very high risk. So again, I wouldn't just say hemodialysis patient, but you also need to look at their liver function. You need to look at what other risk factors they have. But in general, the hemodialysis patients, they can take their medications. You need to treat it on target. So they can take their statins. But I would say that those patients are dealt with a multidisciplinary team. So usually they are under nephrology. And they do see the diabetologist. Number one reason for hemodialysis is diabetes, and the cardiologist. So I would say it would be targeted based on, so if you have a patient who's on dialysis, my question to you is, they can't be with one doctor alone. All the hemodialysis patients are very high risk for cardiovascular disease. So I would say there's no one size fits all. I cannot advise on one best medication for a certain patient. So I would say that they probably, if this is a nephrologist asking the question or a family medicine, I would say that they need a cardiovascular assessment.
Can I add something? I think most likely maybe whoever asked the question, they were thinking about simvastatin because it has more study with dialysis. But in reality, I think all the statin can be used whenever we decide to use it. But I think with dialysis, there is more data with simvastatin, which we don't use too much in our practice anymore.
Yeah, because of the efficacy with simvastatin, but obviously there's a cost issue. And as you mentioned, in the GCC, we deal with a multicultural society and a lot of populations who are moving in and out. And we do still see simvastatin. Again, also, there's a lot of interactions with other medications. So not every statin is equal because some have interactions with other drugs and others don't.
Yes, there was some question about lipoprotein(a). I mean, as a cardiologist, we use it. We actually test it for patients at least once in life. But Dr. Tariq, in the clinic, diabetic clinic, do you use lipoprotein(a) or high sensitive CRP or no?
I mean, it's definitely whenever we can do it, it will give us really very high prediction. So high sensitive CRP is one of the really predictive. So if it's really high, that will push us even in primary prevention to use a statin. It's one of the enhancers on the top of the calculator. What the LPA, I think it's now the recommendation to be tested at least once. And definitely if it's high, also one of the enhancers, the higher the level, the higher the risk factor. So it's, yes, definitely. But some people, unfortunately, they cannot afford it. So then we have to go with the calculator, other enhancers, and so on. But with a good insurance and so on, at least once is recommended.
Yes. And there were two questions for Dr. Walid that I would like to answer it. Just There was one question that if the patient develop angioedema, whether we can still continue on ACE inhibitor or ARB. If the patient develop angioedema while taking ACE inhibitor, that is this contraindication to continue on ACE inhibitor. ARB is still, you can try it, but you have to be very, very careful. And I have to say that Entresto, because it has the neprilysin inhibitors, which actually increase the bradykinin also. If the patient develop angioedema on ACE inhibitor, you cannot switch them to Entresto. There was another question about ghee, the butter, the natural butter, whether it increase HDL or not. It does increase the HDL because it has saturated fat, but unfortunately at the same time it increases the LDL as well. And so we still recommend extra virgin olive oil for the patients. Dr. Mariam, there was a question that what do you think of initiation with the combination therapy rather than monotherapy when it comes to hyperlipidemia?
So again, it depends on categorizing your patient first. For me, this is critical. I do it for the diabetes, categorizing them for the kidney patients, for the dyslipidemia. And the same patient may have multiple categorizations based on the chronic condition they have. So I would initiate combination therapy probably with, so again, there were questions about PCSK9 use. So I would go for PCSK9 after I've tried first with a statin or a combination statin ezetimibe, or if someone was statin intolerant, maybe we can go for a PCSK9, even to get approvals for that. Sometimes, you have to go through this route. Really depends on how high the LDL is, what the other risk factors are. Is there lipoprotein little a? Are there other risk factors? So yes, I do frequently start people for the first time on combination therapy based on their risk profiling. This is a patient maybe who needs an LDL below 70 or an LDL below 55. Why would I start somebody on if on a single drug if I know I'm not going to achieve that target?
Yes, thank you. I would like to actually again remind everybody to scan the QR code because then they can have their presentation and their questions and communication. And there is this webinar is CME accredited, so you will get your certificate very soon. Now, still we have a lot of questions, but for the sake of time, I would like to ask each one of you to give us your very short take-home message of the overall presentations for the audience and for myself as well. Thank you.
Sure.
Dr. Maria, go ahead.
Yeah. So my take-home message would be, I'm not going to focus just on dyslipidemia, although I discussed dyslipidemia, is cardiometabolic risk factors, no matter what they were. They're chronic, they lead to potentially fatal outcomes, unfortunately. Cardiovascular disease, #1 cause of death in our region. And I wish that all physicians really took the time to update themselves with the guidelines on what are the targets, how to classify your patient, and how to educate your patient on the importance of this so they can be compliant and be on board with you and work with you.
Excellent. Thank you very much, Dr. Tariq.
So for me, on the top of what Dr. Mariam said, I mean, always try to hopefully treat, our patient as family. So we don't really have inertia, which something really preventing all of us in taking care of our patient. Always in whatever risk factor we're talking about, there is number to reach or goal to reach, but there is the best way to do it. by utilizing whatever tools in the best way for end organ damage or cardiovascular renal protection. And again, we have to really reduce this inertia by not exaggerating side effects and make it as a bubble and make the benefit as a dot. We should do the opposite, because this is what I see in the practice, unfortunately.
Thank you very much. Let me again thank you both and thank Dr. Walid as well. I personally enjoyed the whole presentations, and I can see that we had a lot of colleagues attending the webinar, and they are all, a lot of them are actually asking where they can find the recording. So congratulations to both of you and Dr. Walid for producing such a fruitful presentation and sharing your information experience with us. And also people are checking and they wanted the QR code, which is on the screen, so you can scan it. With that, I would like to thank our audience as well. Again, thanks, Sarwir, for arranging this meeting and this beautiful project that they have started. And I want to wish you a pleasant and peaceful evening, and God bless all of you. Thank you very much.
Thank
Thank
you.
you, everybody.
Thank you.